Hi, good morning everyone. Today I'm going to talk about sedatives and hypnotics. First, we will learn what are sedatives and what are hypnotics and what is hypnosis and what is insomnia. These are the few terminologies you should know before knowing about the drugs. Okay, sedative is a drug that produces a calming effect and reduces excitement. Hypnotic, this is also a drug which induces and or maintains the sleep. Kindly note the difference what is sedative and what is hypnotic. Hypnotic that produces the calming effect and reduces the excitement. Hypnotic is a drug which induces and maintains the sleep. Hypnosis is different from these two entities, that is the sedative drug and hypnotic drug. Hypnosis is a trance-like state in which the subject becomes passive and highly suggestible. Insomnia is a sleeplessness during night time. Before going to learn about the drugs, we should know the phases of sleep. We should learn about the sleep cycle. As we know, there are five stages. Basically, total five stages. Stage zero is a awake stage. Okay, so we have stage 0, 1, 2, 3, 4, and followed by stage 4, there is a REM sleep. So stage 0 is awake, that constitutes 1 to 2% of sleep time. Stage 1 is called dozing, which constitutes about 3 to 6% of sleep time. However, stage 2 is the maximum part of the sleep is uh, the maximum phase where the person's sleep is in the stage 2, that is 40 to 50% of the sleep time goes in the stage 2, and stage 3 is 5 to 8% of sleep time, and stage 4 10 to 20%, and REM sleep 20 to 30% sleep time which is spent in REM. So during stage 2, 3, 4, heart rate and BP respiration are steady and muscles are relaxed. What happens in the sleep cycle? It starts from stage 0, then 1, 2, 3, 4, then REM, and this will occur over a period of 80 to 100 minutes, and this cycle repeats. That's what is called sleep cycle. So what and all happens in from this stage 0 to REM sleep, we will learn. Stage 0 is awake, I said, from the lying down to the falling asleep, and there occurs in nocturnal awakenings. It's just 1 to 2% of sleep time. So basics. The important is from stage 1 to REM sleep. Stage 0, you should know that it's only awake stage and it is only 1 to 2% of the sleep time, and where it starts from lying down to the falling asleep. What is the EEG activity? EEG shows alpha activity when eyes are closed and beta activity when eyes are open, and eye movements are irregular and slowly rolling. Stage 1, this is called dosing, where the alpha activity is interspersed with theta waves. Here the eye movements are reduced, but there may be bursts of rolling and neck muscles relax. It constitutes about 3 to 6% of sleep time. Coming to the stage 2, which is the maximum part, that is 40 to 50% is this stage 2 comprises 40 to 50% of sleep time, where we can see the little eye movements, subjects are easily arousable, and EEG shows theta waves with interspersed spindles and K complexes, which can be evoked on sensory stimulation. Coming to the stage 3, that is deep sleep transition, where the eye movements are few and subjects are not easily arousable at this stage, and EEG shows theta, delta and spindle activity, and K complexes can be evoked with a strong stimulant. Okay. Coming to the stage 4, this is called cerebral sleep. Okay. Here, the eyes are practically fixed. Subjects are very difficult to arouse. Night terror can occur at this stage, and EEG shows delta activity and K complexes cannot be evoked at this stage. K complexes can be evoked in stage 3 as well as stage 2. In stage 2, just a simple sensory stimulation will evoke the K complexes. However, in stage 3, this will be evoked with a strong stimuli. Coming to the next stage of the sleep, that is REM sleep, that is also called paradoxical sleep. Okay, this is marked irregular and darting eye movements. Dreams and nightmares occur, which may be recalled if the subject is aroused. And what happens to the vitals, heart rate, like heart rate and BP? The heart rate and BP fluctuate, respiration is irregular, muscles are fully relaxed, but irregular body movements occur occasionally. Erection can occur in males, and about 20 to 30% of the sleep time is spent in REM. EEG shows all frequency waves. Here also K complexes cannot be elicited. K complexes can be elicited only in the stage 2 and 3. Okay, then not no. Okay, I already said the sleep cycle is constitutes around 80 to 100 minutes. It starts from stage 0, 0, 1, 2, 3, 4, and then REM sleep. It will occur over a period of 80 to 100 minutes, and this stage keep repeated cyclically. Okay, coming to the drugs, the classification of the drugs, sedatives and hypnotics goes like this. We have barbiturates, benzodiazepines, newer non-benzodiazepine hypnotics. Barbiturates consist of long-acting, short-acting, ultra-short-acting drugs. In long-acting, we have phenobarbital. In short-acting, we have pentobarbital and butobarbital. And ultra short acting, we have thiopentone and methotrexate. In benzodiazepines, we can further classify them as hypnotic agents, anti-anxiety agents, and anticonvulsants. In hypnotic groups, we have diazepam, nitrazepam, alprazolam, flurazepam, clobazam, temazepam, triazolam. In anti-anxiety group, we have again diazepam, lorazepam, clobazam, oxazepam, chlorodiazepoxide, alprazolam. In anticonvulsant group, we have diazepam, lorazepam, clobazam, clonazepam. We can see that diazepam is having all the activity, like it is used as a hypnotic, anti-anxiety, and anticonvulsant. And lorazepam, clobazam can be used as an anti-anxiety as well as anticonvulsant. Even clobazam can also be used as hypnotic also. Some of the drugs have all the actions. Coming to the newer non-benzodiazepine hypnotics, they are Zopiclone, Zolpidem, Zolpidem. This is the classification of sedative and hypnotics is important. Kindly you have to keep reading, then you will remember it. Okay. And always you should remember what is sedative and what is hypnotic. Sedative is the drug which subdues the excitement and calms the patient. However, hypnotic is the drug which produces the sleep, which is similar to that of the normal sleep, normal arousable sleep. Okay. Coming to the barbiturate, they earlier these were the popular hypnotics and sedatives for the last century up to 1960. However, we have better efficacy and safety drugs than barbiturates. So right now we are not using as a sedative and hypnotic these barbiturates. Earlier they were people were using as an hypnotics and sedatives. These are the prototype CNS depressants. How they act. Before that, we should know this receptor, that is GABA, benzodiazepine receptor chloride channel complex. It is a pentamer which consists of 2 alpha, 2 beta, and gamma subunits. Okay, and we have a GABA site. GABA will bind to the GABA receptor site, which is present in the beta subunit, and barbiturate will bind to the alpha beta interface, and diazepam will bind to the alpha gamma. Diazepam nothing but benzodiazepines. Okay, this that's where the benzodiazepine will bind is that alpha gamma interface, that is called benzodiazepine receptor. And we will learn this antagonist flumazenil which is a competitive antagonist. Even it will bind to the alpha and beta interface. This flumazenil, which is a competitive antagonist at benzodiazepine receptor. It is competitive antagonist for the benzodiazepines. So that will also bind to the alpha and gamma interface. So basically you should know at least these three receptors, that's barbiturate receptor, GABA A receptor, and benzodiazepine receptors. This is this whole complex we call it as GABA benzodiazepine receptor chloride channel complex. They act primarily, these barbiturates act primarily at the GABA and benzodiazepine receptor chloride channel complex, the binding site which is located on alpha beta subunit. They potentiate GABAergic inhibition by increasing the lifetime of chloride channel opening induced by the GABA. They have a GABA mimetic action. That means at higher concentration, they directly increase the chloride conductance. And they in higher concentration, they also inhibit the calcium dependent release of neurotransmitters. They also depress glutamate induced neuronal depolarization through AMPA receptors. Very high concentrations, it will depress voltage sensitive sodium and potassium channels. These are all the actions that will be exerted by the barbiturate at higher doses. But the main primary action, that is, it is having GABAergic, it potentiates the GABAergic inhibition by increasing lifetime of chloride channel opening. That means it increases the duration of chloride channel opening. So that is primarily exerted through the acting on the GABA benzodiazepine receptor chloride channel complex. And they also have the GABA mimetic action. This too is very important. Apart from that, higher concentration, what and all it will exert an action. That is also can remember. This is what I said, GABA benzodiazepine chloride channel complex. These barbiturates will either bind to the alpha or beta subunit or interface. Then it will increase the duration of chloride channel opening. So increased chloride conductance, which causes the hyperpolarization. So it brings down the excitation. Coming to the pharmacological actions of barbiturates, they are a general depressants for all the excitable cells, but the CNS is most sensitive. And this, what are the CNS effects? It produces the dose-dependent effects. That is, at a lower dose, it produces sedation, still higher dose sleep, still higher dose anesthesia, and still higher doses, it can produce coma. Hypnotic dose that will shorten the time taken for fall asleep and increases sleep duration. And it also reduces night awakenings, REM, and stage 3. REM is, random eye movements. And stage 3 and 4 of the sleep cycle are decreased. REM and NREM sleep cycle is disrupted. That is the main disadvantage of this drug, which disrupt the normal sleep cycle. And coming to the other actions of this barbiturate over the other systems like respiratory system, cardiovascular system. Coming to the respiration system, it will depress the respiratory center. It usually occurs at higher doses. In CVS, at hypnotic doses, it produces slightly falling blood pressure and heart rate. However, higher doses can produce marked falling blood pressure, and also it decreases the cardiac contractility. Still higher dose can produce even reflex tachycardia, and very higher doses can produce cardiac arrest. It all mainly having dose dependent effect. As a hypnotic, it will just produce slightly decrease in BP and heart rate. Coming to the skeletal muscles, hypnotic doses have a little effect on the skeletal muscle. Anesthetic doses will reduce the muscle contraction by action on the neuromuscular junction. And they also produce, coming to the smooth muscle, they decreases the smooth muscle tone and motility. Okay. Then on the bronchial, ureteric, vesical and uterine muscles, the action is not significant. In the kidney, they tend to reduce the urine flow by decreasing blood pressure and increasing ADH release. So in toxicity, oliguria can occur. Then coming to the pharmacokinetics of barbiturates, they are well absorbed from the GIT. They have a wide distribution because of higher lipid solubility, and CNS penetration is high. The redistribution is seen with thiopentone. That means that is the reason why after IV injection, consciousness is regained in 6 to 10 minutes. That is because of rapid redistribution. However, the ultimate disposal occurs through metabolism, that is elimination phases over around 9 hours. The metabolism takes place in the liver, excretion in the kidney. Phenobarbital is an enzyme inducer, so many drug interactions can be encountered with this drug. Coming to the therapeutic uses, nowadays we are not using barbiturates as a sedative or hypnotic. The main use of phenobarbital is in epilepsy and as well as congenital non-hemolytic jaundice and kernicterus because of its enzyme inducing property. This phenobarbital will induce an enzyme called glucuronide transferase. So that will convert unconjugated bilirubin into the conjugated bilirubin. That's why it is used in the treatment of jaundice and kernicterus. Okay. Next, coming to the thiopentone, it is one of the drug which is used as a IV inducing agents in anesthesia. These are the only two barbiturates currently used. Coming to the adverse effects, the most common adverse effects seen with the barbiturates is the hangover. It also causes distortion of mood, impaired judgment, and fine motor skills, idiosyncrasy, and that means the barbiturate produce excitement in some of the individuals. That is what is called idiosyncrasy. Normally they are the CNS depressants, but in some individuals, especially in case of elderly population, this barbiturate can produce excitement, and they also precipitate the porphyria in susceptible individuals. Then the hypersensitive reactions can also be encountered with this drug, like hypersensitive reactions like rashes, swelling of eyelids, lips can occur. Phenobarbital, because of his enzyme inducing itself also, the enzyme which is used for metabolizing phenobarbital itself, it will induce. So that will result in tolerance, that pharmacokinetic as well as pharmacodynamic tolerance can be seen with this phenobarbital. The abuse liability is the major disadvantage, and it also produces drug dependence, both psychological as well as physical. Drug automatism can occur with this drug. That means automatism is once the patient takes this drug and he forgets that he has taken the drug, it produces amnesia. So that is the reason patient keeps on taking the drug, and it can result in toxicity. That is what we call it as drug automatism. Next, it can produce CNS depression, so it can result in hypotension. It also produces respiratory depression, and withdrawal symptoms are also occurred with this drug. Once if we wean off the drug, take off the drug, then it can result in withdrawal symptoms like excitement, hallucination, delirium, convulsions, and death. What the acute toxic, how to manage the toxicity of barbiturates, because it is very common. Barbiturates are most commonly used for suicide in case of medical students or medical fraternity people. These are the these are the common available drugs. That means the person can easily what we can easily take from the they are not over the counter drugs, but the medical personnel can easily have approach to this drug. So that's why it's more common with the medical professionals. So we should learn how to manage the toxicity of barbiturates. That is supportive measures always first. That is, we have to ensure the airway, breathing, circulation. Then if required, we have to go for the artificial ventilation, oxygen of course. Then artificial ventilation if required, then we have to give the gastric lavage. And as we know that this drug is an acidic drug, so forced alkaline diuresis can be done with the help of sodium bicarbonate 1 milliequivalent per kg IV with or without mannitol. Hemodialysis and hemoperfusion can also be done. This particular group of drugs doesn't have any specific antidote. It's mainly through supportive care we have to manage the barbiturate poisoning. Okay. Coming to the contraindications of barbiturates, they are acute intermittent porphyria, liver and kidney disease, as well as obstructive sleep apnea. Drug interactions of phenobarbital, especially because it is one of the enzyme inducing agent. It induces many CYP enzymes, so it reduces the efficacy of the drugs which are metabolized using this enzyme, like warfarin, steroids, tolbutamide, thiophanine, graziopulmine, chloramphenicol. It reduces the efficacy of these drugs because it induces the CYP enzyme, which or so that these drugs will be metabolized faster. And it also causes additive CNS suppression with other CNS suppressants like alcohol, antihistaminics, and opioids. Sodium valproate is an enzyme inhibitor. It increases the phenobarbital levels. And phenobarbital competitively inhibits and induces phenytoin as well as imipramine. So it is having complex interaction. Phenobarbital decreases the absorption of graziopulmine from the GIT. So it's better not to give these two drugs together. Coming to the next group of drugs, that is benzodiazepines. We have already learned the classification, just recall of it. That is, we have hypnotics, we have anti-anxiety drugs, we have anticonvulsant drugs. In the group of hypnotics, we have diazepam, nitrazepam, alprazolam, flurazepam, clobazam, temazepam, triazolum. Anti-anxiety, we have diazepam, lorazepam, clobazam, oxazepam, clodiazepoxide, alprazolam. Anticonvulsant, we have diazepam, lorazepam, clobazam, clonazepam. This diazepam, lorazepam, clobazam is there almost all. Lorazepam is mainly has an anticonvulsant and anti-anxiety. Coming to the what are the advantages of benzodiazepines over the barbiturates? Right now we are not using barbiturate, but we are using benzodiazepines very often. What is the reason for that? First reason, they have the high therapeutic index, and they produce a slower degree of neuronal depression than the barbiturates. And at the hypnotic doses, they doesn't produce any effect on the RS or the CVS, that is respiratory system or cardiovascular system, and they doesn't produce any other action on any other system also. Like this, barbiturates are producing like kidney, they are decreasing urine output, and they increases the ADH release, and in smooth muscles they're increasing the decreasing the tone. Like this, no other effect. These drugs doesn't affect on any other systems also. And there is a less distortion of sleep architecture that we have seen in barbiturates. The REM and NREM sleep cycle was disrupted, but however we are not seen with this group of drugs. And it doesn't have any microzymal enzyme induction. We have seen the phenobarbital is an enzyme inducer, and there were so many interactions was seen with that drug. So benzodiazepine, there are no microsomal enzyme induction, so there is no drug interactions, and they are lower abuse liability. And the foremost important thing is that even they have a specific antagonist. In case of poisoning, we can use this antagonist for the treatment, flumazenil. First is they have higher therapeutic index, and if toxicity occurs also, we have a specific antagonist for the management of toxicity, that is flumazenil. And they have even lower abuse. So many advantages we have seen with the benzodiazepines compared to that of barbiturates. So we should learn about benzodiazepines now. Again, this drug also will act on the same receptor. Already remember this GABA benzodiazepine receptor chloride channel complex, where we can see this alpha gamma interface. This diazepam is acting. Okay, the site of action, primary site, is a GABA benzodiazepine chloride GABA benzodiazepine receptor chloride channel complex, where it enhances presynaptic and postsynaptic inhibition, thereby increases the frequency of chloride channel opening. Barbiturates increasing the duration of chloride channel opening. Here, they increases the frequency of chloride channel opening, which is induced by submaximal concentration of GABA. They enhances the affinity of GABA to the receptor. They have a GABA facilitatory action. However, barbiturates have the GABA mimetic action. Benzodiazepine doesn't have GABA mimetic action, they have a GABA facilitatory action. So all these things result in increased chloride conductance, which can result in hyperpolarization of the neurons and which brings down the excitement. Otherwise, it can cause CNS depression. Okay. Where and all it acts? What are the sites of benzodiazepine action? It acts mainly on the midbrain and ascending reticular formation. This is a site where which keeps the person awake. That's wakefulness. So it will act there and produces not hypnosis. It exerts hypnotic action by acting on the midbrain and ascending reticular formation. There is different, hypnotic is different and hypnosis is different. Please don't use these two terms interchangeably, as both are entirely different. Hypnotic is a drug which induces the sleep, normal arousable sleep. However, hypnosis is a trance-like state. Okay, the both are different. Coming to the this under hypnosis is the trance-like state where the person is highly suggestible. So there is a total difference is there. Please make sure that the hypnotic and hypnosis is not the same. They are different. Okay, next coming to the, it will even act on the limbic system. On acting on the limbic system, it produces the anti-anxiety effects, and through acting on the medullary side, it produces muscle relaxation. This is it's a centrally acting skeletal muscle relaxant. It doesn't have any smooth muscle action, only skeletal muscle it will act. And it also produces ataxia by acting through cerebellum. That is a side effect. Ataxia we don't want, but it is occurring with this drug. Okay, what are the pharmacological actions? As already told, it exerts anti-anxiety action. It produces hypnosis. That means it hastens the onset of sleep, reduces intermittent awakenings, increases total sleep time, prolongs the stage 3 and 4 phases of sleep cycle. It even produces anesthesia. It produces it is called as a centrally acting skeletal muscle relaxant. So it produces muscle relaxation by acting through a medullary site. And it also exerts anticonvulsant effect and produces even amnesia. Coming to the pharmacokinetics, they have a slow oral absorption. Absorption from IM sites is irregular except for the lorazepam. They have a higher plasma protein binding, that is this varies markedly from one benzodiazepine to another benzodiazepine. Like flurazepam has 10% plasma protein binding, however diazepam has 99% plasma protein binding. They are widely distributed in the body and they are even lipid soluble and enters the brain rapidly. They have a two-phase plasma concentration decay curve. First is because of distribution and second is due to elimination. So we have both is distribution T-half and elimination T-half can be seen with this group of drugs. And they have a long elimination T-half. This benzodiazepine group of drugs are primarily metabolized in the liver, mainly by CYP3A4 and 2C19. And some of the benzodiazepine like diazepam, which undergoes even enterohepatic circulation, and benzodiazepines also crosses placenta and secreted in the milk, so should be careful while administering in a pregnant women or lactating women. What are the uses of benzodiazepines? Mainly, they are used as an hypnotic agents. That means in case of insomnia. Insomnia is the state where patient doesn't have sleep during night time. That we call it as insomnia. So it is used as an hypnotic agent in the treatment of insomnia. It is used as an anti-anxiety drug in the treatment of anxiety states like generalized anxiety disorder. Or, as a pre-anesthetic medication, it is used even to reduce the anxiety. Okay, they are used as an anticonvulsant drugs, especially in case of status epilepticus. Lorazepam, diazepam are used, and even febrile seizures, we are using rectal diazepam, and clobazam also. Then these drugs are used in treatment of alcohol withdrawal syndrome, like diazepam and lorazepam and chlordiazepam oxide. These three drugs are preferred. They are used even as a centrally acting muscle relaxant. Again, diazepam, lorazepam we can use. They are used even in conscious sedation, and they are also used in before ECT. Uh, what is ECT? Uh, ECT is they are used before ECT. That means electroconvulsive therapy. Okay, that time also to reduce excitement and to subdue the to make the patient calm. We can use this drug, and they are also used during electrical cardioversion of arrhythmias, and the minor procedures also. It is used, and it's also used in case of cardiac catheterization, endoscopies, DNC, like obstetrics procedure, that is dilatation and curettage. In all these conditions, diazepam is used IV to produce a calming effect, amnesic effect, analgesic effect, as well as muscle relaxing effect. So, because of these, to produce all these effects, this one drug, diazepam, we can use in all these procedures during the procedures before the procedure, we can use this drug. It is also used as an adjuvant to treat dyspeptic symptoms. Coming to the adverse effects of benzodiazepines, relatively they are safer drugs, but still they have some adverse effects. Like in at hypnotic doses, they produce dizziness, vertigo, ataxia, disorientation, amnesia, and impairment of psychomotor skills. And hangover is less seen with this group of drugs. However, barbiturate it is more commonly seen. Okay, they produces even weakness, blurring of vision, dry mouth, and urinary incontinence. Paradoxical stimulation, irritability, sweating is mainly seen with the flurazepam. Increase in nightmares and behavioral alterations is especially seen with the flurazepam and nitrazepam. Dependence liability is very low. Withdrawal syndrome, it produces even withdrawal syndrome that is usually mild. However, barbiturates they have a higher withdrawal symptoms. We have seen excitement, agitation, insomnia, all this. Here it is very mild. Only in some of the cases we'll encounter this withdrawal symptoms, like again anxiety, insomnia, restlessness, malaise, loss of appetite, bad dreams, agitation, panic reaction, tremors. Very rarely. Okay, and another most peculiar point of this is this benzodiazepine group of drugs like diazepam even produce floppy baby syndrome, where the baby will be having flaccidity and respiratory depression. Coming to the antagonist at a benzodiazepine receptor, we know I said this benzodiazepine group of drugs have a specific antagonist that we call it, that is called as flumazenil. Flumazenil. So whenever the poisoning occurs with the benzodiazepine group of drugs, we can use this drug. We have a non-competitive benzodiazepine which can be used as a research tool, that is bicuculline, and which is an inverse agonist at the benzodiazepine receptor, that is beta carotene. This can be used, they are used basically as a research tool. Flumazenil is having therapeutic importance. It is a first, it is a benzodiazepine receptor competitive antagonist. It is used to reverse the benzodiazepine sedation and anesthesia. It is also used in benzodiazepine overdosage. I'm sorry, summary is that it is benzodiazepine overdosage. This is overdose and toxicity of Z compounds also we can use. We have the last group of drugs, that is, they are called Z group of Z compounds. They are non-barbiturate, non-benzodiazepine group of drugs. So in their toxicity also we can use this agent. Adverse effect, it produces agitation, discomfort, tearfulness, anxiety, coldness, and withdrawal seizures. They are occasional. The newer group of drugs, that is newer non-benzodiazepine hypnotics. They are also called non-Z compounds. They are also called non-benzodiazepine hypnotics. The drugs under the group we know Zopiclone, Zolpidem, Zolpidem. They are chemically different from benzodiazepines. They act as agonists on the specific subset of benzodiazepine receptor. Mainly, they act selectively on the alpha 1 subunit containing benzodiazepine receptors. So they produces only hypnotic action and as well as amnesic action. They doesn't produce any anti-anxiety effect or muscle relaxation effect or anticonvulsant effect. So they have a lower abuse potential than other hypnotic drugs like even benzodiazepine and barbiturates. Because of the shorter duration of action, they are being preferred over the benzodiazepines for the treatment of insomnia. For the treatment of insomnia, currently this group of drugs are preferred. So Zopiclone is the first non-benzodiazepine hypnotic. It acts as an agonist. All the benzodiazepine they act as hypnotic on the alpha 1 subtype of benzodiazepine receptor. So they produces hypnotic action. They doesn't alter REM sleep. They only prolong the stage 3 and 4 sleep cycle. That's why they doesn't disturb the sleep architecture. And in this drug, next day morning impairment can be seen. So it is basically used to wean off insomniacs taking regular benzodiazepine medication. Okay, it is indicated mainly for the short-term insomnia. That means short-term, when we call it a short-term insomnia, patient having insomnia for a duration less than 2 weeks. That we call it a short-term insomnia. So in that condition, we can go for Zopiclone. The side effects seen with this drug are metallic or bitter taste, impaired judgment and alertness, and psychological disturbances, dry mouth and mild dependence, but is not significant. Coming to the S-Zopiclone, it is an active S-enantiomer of the Zopiclone, which has been approved for the treatment of insomnia because it is also having little tolerance and physical dependence. Mainly, it is used in the treatment of short-term insomnia as well as chronic insomnia. Chronic insomnia when it is present for more than 3 weeks or 21 days, whichever we can take. Zolpidem, it is a selective benzodiazepine receptor agonist which is having a pronounced hypnotic effect. It shortens the sleep latency and it increases the sleep duration. And all these Z compound doesn't have anticonvulsant, muscle relaxant, anti-anxiety effect that is common for all Z group compounds. So they have only increases the sleep duration or some stage 3 4 of the sleep cycle without disrupting any sleep architecture. They increases the sleep duration. That's why they are basically using the treatment of insomnia. So indication again short-term insomnia used in sleep onset insomnia and for intermittent awakenings. In this Zolpidem, next day sedation is minimal. However, the previous drug, Zopiclone, next day impairment was occurring with this drug, but this Zolpidem has less chance of next day sedation. So side effect morning sedation or prolongation can occur if it is taken at the late night. So what are the advantages of Zolpidem? It is relatively lack of effect on sleep stages. It is having minimal residual daytime sedation or fading of hypnotic action on repeated use. There is no or little rebound insomnia on discontinuation. Near absence of tolerance, no abuse potential, safer in overdose. These are the advantages of Zolpidem. As per se, all Z compounds. Zolpidem, again, it's also same mechanism of action. It is having mild bioavailability because of first pass metabolism. Uses again sleep onset insomnia, the effect on sleep stages and REM or less. So it doesn't prolong the sleep time or reduce the number of awakenings. But what it does is it only onset it once the patient sleep for getting sleep only short minimum 15-30 minutes in that the person should sleep off. So the sleep onset insomnia where it is difficulty to go for a sleep, in that condition Zolpidem is more preferred. Okay, because of brevity of action, it can be taken at late night. So if it is just sleeping time and waking time, if it is more than 4 hours, it is sufficient to take this drug. So it doesn't causes morning sedation. no daytime anxiety or rebound insomnia. It is also no tolerance or dependence. Over the advantages of Z compounds, they produce normal sleep pattern. Risk of tolerance is very less. They are rapid and short acting. No hangover is seen, and they have lower abuse potential. No rebound insomnia and discontinuation. They are safer in overdose. Thank you.